Developmental disorders of the urinary tract are very common. Fortunately, most of these anomalies do not produce symptoms and are often discovered only by chance. For example, 1 in 800 people is born with only one kidney, or with the solitary horseshoe kidney formed by the fusion of the kidneys in the midline. Patients with such anomalies are usually asymptomatic, and the congenital defect is often noted on routine X-ray examination for some other disease, or if the affected person is being considered for kidney donation. Clearly, these individuals cannot donate their solitary kidney for transplantation. The most important developmental disorder of the urinary tract is autosomal dominant polycystic kidney disease, ADPKD, which is inherited as a Mendelian trait at a rate of 1 to 1,000. In 85% of all cases, the disease is related to the mutation of a gene encoding polycystin 1, a cell-to-cell adhesion molecule holding cells together. ADPKD affects the kidneys bilaterally. Both kidneys are enlarged, contain numerous cysts, and weigh 3,000 to 4,000 grams, which is 20 times more than the normal weight of 150 to 200 grams. These cysts, which are derived from obstructed tubules, contain fluid. The reasons for the obstruction of tubules are unknown. Cystic change in the tubules gradually impairs renal function. Most affected patients develop renal failure by the age of 40 to 50 years. ADPKD must be distinguished from several other congenital kidney diseases, most of which present during infancy and childhood. The most important of these is multicystic renal dysplasia. In contrast to ADPKD, multicystic renal dysplasia is usually unilateral. The enlarged abnormal kidney may be palpated by either a parent or the pediatrician. This condition should be distinguished from renal tumors of infancy and adrenal neuroblastomas, which are two other causes of abdominal masses in that age group. Unilateral renal lesions can easily be removed without consequences, and if the kidney is normal, the patient has an excellent chance for complete recovery. Acute glomerulonephritis is an immune-mediated inflammatory glomerulopathy that occurs 1 to 2 weeks after an acute infection, most often a streptococcal upper respiratory disease. The disease typically affects children. Before the era of antibiotics, post-streptococcal glomerulonephritis was very common. Today, it is uncommon in the United States, but is still prevalent in underdeveloped countries and even in some countries as close to the United States as the Caribbean islands. Acute post-streptococcal glomerulonephritis is caused by the antibodies produced in response to infection with certain streptococcal strains. The antigen-antibody complexes are trapped in the glomerular basement membranes, where they activate complement and thus attract inflammatory cells into the kidney. On histological examination, the glomeruli appear hypercellular because they contain an increased number of mesangial cells and numerous inflammatory cells. These cells compress or occlude the capillaries, thereby preventing blood flow through the glomeruli. Acute glomerulonephritis presents with nephritic syndrome. The damaged basement membranes of the inflamed glomeruli become permeable, which accounts for the proteinuria and hematuria. The urine of these patients typically appears murky brown, resembling bouillon soup. Loss of proteins, mostly albumin, in the urine causes hypoalbuminemia, which in turn results in edema. The hypertension is caused by reduced blood flow through the arterioles, leading to the inflamed glomeruli, which elicits a release of renin from the juxtaglomerular apparatus in the afferent arteriole. Reduced blood flow also results in oliguria. The glomerular inflammation is usually short-lived, and most patients recover completely. In 1% to 2% of affected patients, however, the disease may cause acute renal failure. Chronic glomerulonephritis and end-stage kidney disease complicate acute glomerulonephritis in less than 10% of cases. Crescentic glomerulonephritis is a term used to describe severe glomerular injury accompanied by the formation of an exudate on the glomerular urinary space. The exudate consists predominantly of macrophages that have crossed through the damaged glomerular capillaries into the urinary space between the capillary tufts and Bowman's capsule. The term derives from the fact that the inflammatory cells surround the compressed capillary loops in the form of a crescent moon. Crescentic glomerulonephritis usually occurs after focal necrosis of the glomerular capillaries. Such focal necrotizing glomerulonephritis is typically found in Goodpasture syndrome, an autoimmune disease characterized by the formation of antibodies to the body's own basement membrane component, collagen type 4. Injury of collagen type 4 in the lungs causes intra-alveolar hemorrhage. In the glomeruli, the antibodies cause rupture of the basement membranes. Macrophages exit through the holes in the basement membrane and accumulate in the urinary space, forming the crescents that compress the capillary loops. Because no blood flows through the compressed capillary loops, glomerular filtration ceases and anuria ensues. Clinically, the disease is known as rapidly progressive glomerulonephritis, RPGN. Most patients never recover, and their survival depends on continuous dialysis or kidney transplantation. Crescentic glomerulonephritis is a descriptive diagnosis. In addition to Goodpasture syndrome, it may be caused by Wegener's granulomatosis, polyarthritis nodosa, or severe post-streptococcal glomerulonephritis. Once the diagnosis of crescentic glomerulonephritis is made by kidney biopsy, it is important to test the patient serologically to determine whether the blood contains specific antibodies. Finding of antibodies to collagen type 4 will confirm the diagnosis of Goodpasture syndrome. Antibodies to neutrophil cytoplasmic antigens, ANCA, are found in Wegener's granulomatosis and microscopic polyarthritis. Membranous nephropathy is an immune-mediated glomerulopathy characterized by diffuse thickening of the glomerular basement membranes secondary to massive deposition of immune complexes. In contrast to acute glomerulonephritis, which causes nephritic syndrome, membranous nephropathy presents with a typical nephrotic syndrome. There is no evidence of inflammation. The glomeruli do not contain any inflammatory cells, and the urine is devoid of RBCs and inflammatory cells. Membranous nephropathy is one of the most common immune nephrotic syndrome of adults. In 85% of the cases, its etiology remains unknown. In addition to these idiopathic cases, a secondary disease of the same morphology can affect patients who have developed antibodies to tumors, drugs, or infectious agents, such as hepatitis B virus or Treponema pallidum. Light microscopy reveals that the glomeruli have thick basement membranes, but are normocellular. That is, they show no proliferative or inflammatory changes. Immunofluorescence microscopy demonstrates the granularity of these deposits. On electron microscopy, one may see that the thickening of the basement membrane is attributable to the deposition of dense immune complexes. Membranous nephropathy presents with the typical symptoms of nephrotic syndrome and does not respond to therapy. Proteinuria persists in most patients for years, but the disease progresses in only 40% of patients. These patients eventually develop chronic renal failure and require dialysis or renal transplantation. Focal segmental glomerulosclerosis, FSG, is currently the most common cause of nephrotic syndrome in adults. However, it may occur in children as well. It is not a single clinico-pathologic entity, but rather a group of diseases that share some common features and present with partial scarring of glomerular loops. Focal means that some but not all glomeruli are affected, whereas segmental means that only some capillary loops and an affected glomerulus are scarred. FSG can be classified as primary or secondary. In both forms, the disease presents with proteinuria and nephrotic syndrome, which is unresponsive to corticosteroid therapy. The primary form of FSG occurs most often in children, and the cause of it remains unknown. Often, the physician thinks that the child has lipoid nephrosis, but the proper diagnosis becomes evident when the child does not respond to steroid treatment, or when nephrotic syndrome recurs after steroid therapy. Secondary FSG occurs in a variety of diseases and is encountered in overtly obese persons, and persons infected with human immunodeficiency virus, HIV, and those with sickle cell anemia following intravenous drug use, and in other conditions. The obese patients respond well to weight reduction and treatment with angiotensin-converting enzyme inhibitors. Some patients with secondary FSG may benefit from corticosteroid treatment, but those with HIV do not improve, and in most instances progress to end-stage renal disease. Kidneys may be affected by several variants of primary immune-mediated glomerulonephropathies. Common to all of these glomerulopathies, which carry names such as IgA nephropathy, Buerger's disease, membranoproliferative glomerulonephritis type 1 and type 2, and focal proliferative glomerulonephritis, is that they have a chronic course. They do not respond to treatment, and they slowly but inexorably progress to end-stage kidney disease. Kidney biopsies show that these diseases have unique and diagnostic features. Clinically, these chronic glomerulopathies may present as nephrotic syndrome or nephritic syndrome, with some hematuria, or they may be associated with only mild urinary findings, such as microscopic hematuria and proteinuria, and no clinical symptoms. Chronic proliferative glomerulonephritis may occur in the course of systemic autoimmune diseases, most notably in systemic lupus erythematosus, SLE. Approximately 60% to 70% of patients with SLE develop some renal manifestations. The glomerular changes vary from mild to severe, and histologic findings indicate glomerulonephritis or membranous nephropathy with no proliferative changes. The glomerulonephritis of SLE responds well to corticosteroid treatment. Most, if not all, immune-mediated glomerulopathies can progress to end-stage kidney disease. These immune-mediated diseases, terminating in uremia, have traditionally been called chronic glomerulonephritis. However, by the time chronic renal failure has developed, there has been no evidence of inflammation. Hence, the term glomerulonephritis seems unjustified. Furthermore, all chronic glomerulopathies, be they immune, metabolic, or circulatory, appear ultimately identical. Because the morphologic study of terminally insufficient kidneys does not indicate the nature of the pre-existing disease, it is best to be non-committal and characterize such kidney diseases as end-stage glomerulopathy. Thank you all for watching the video. If you have any other suggestions that are similar to videos like these, please let me know in the comments below. Thank you.